Patients, yeah, patients who already know are using substances. So that's the other question, that it's for patients that we know are using.
So ideally, this is something we would bring up in the peripartum period, right before delivery. And so, at least in my experience, that often people are still using drugs at that time. But unfortunately, as we know, lots of people who have substance use disorders for lots of reasons have very delayed presentations to us in the healthcare system. So I think it's for both. It's for both people who are using drugs, but also really importantly for people who are on substance use disorder treatment and or are contemplating substance use disorder treatment, because we know lots of women are concerned about substance use disorder treatment because of harms in the either during pregnancy or during lactation, fears of exposure. And so we really wanted to empower both patients and providers that those fears really should be minimized. And we always have to hold, which I think is very hard to do in pregnancy and lactating individuals, that the risk of withholding treatment doesn't come without another risk, right? Which is exposure to non-prescribed substances. Uh, and those risks are much higher and much less well understood. So that was really, we really wanted that to inform the patient
Is
handout.
is there anything that you learned in the process that surprised you when creating these documents?
Yes, it's not a surprise as a women's health researcher that's chronically underfunded and undervalued, but the lack of evidence to inform these guidelines is just shocking, given the universality of like delivery and lactation, and then also the shifting epidemiology of substance use across North America in particular, with the increasing incidence, and just the we just still don't know so much. And so it made writing the guideline very difficult, and we've gotten lots of very good questions. I think both like our guideline was too conservative based on what we know, and then also on the other side, too liberal based on what we don't know. So that was hard.
And then what is on your radar at the moment that we can look forward to hearing about in the future in your specific field?
I do think, like I'm working with Kate Standish, for example, and Davita Schiff. I do think that, there's been some investment into some really exciting interventions for this population. I think it's right now more focused on, supporting women with lactation specifically, which is so exciting in the postpartum period, who have substance use disorders, interventions like doula or night nurse. And so I think that's really exciting. I think importantly, we still need more information about the pharmacodynamics. So I think we have to be really creative about working together across disciplines to be able to collect some of that more scientific information. Not that the other isn't science, but pharmacodynamic information, like is fentanyl getting into the milk supply? Like we just don't know that. And so I think it's a very difficult research to do, but it's still really needed. So I think making progress though.
And then what more do we need to know on this topic? I mean, I know there's a lot, but if there was one thing finish off that you would like the audience to, stick with the audience, what would that be?
Yeah, I think I wrote this guideline. We wrote this guideline a few years back, and I feel like I myself have learned and changed. And one voice that was missing in the absence of this process was a person with lived or living experience. And so I actually think that we need to be integrating those people in our guideline development, and then particularly with a patient handout, because I think our communication could be much better than we're doing right now. And so if I was to if I had a magic wand and I could do this again, that's how I would change the process. And I think that um, you know, if there's anything this moment is teaching us right now in healthcare and public health is that we have to learn how to be better communicators with our patients because they are going elsewhere for information. And um, just saying no, that or being paternalistic is really pushing people away. So I think anyways we can first of all, really learn how to be expert communicators and then also include people in our best practice development processes. Um, I feel like that could change, the trajectory. It would have enhanced the quality of this work, and if we do it again, that's what I would do differently.
Well, thank you so much for those final, bits of information that will help us in the future, and hopefully we can get more people involved. And I would like to remind the audience that these topics will be addressed at the 2026 Kansas Breastfeeding Conference, which is October 15th. So don't forget the registration link is now live, so you can go ahead and go sign up for that. Thank you so much, Dr. Harris, for joining us, and I look forward to meeting you at the conference. So next up, we will be introducing Dr. Lovia George. Dr. Lovia George is a neonatologist at Children's Mercy, Kansas City, and the medical director of the University of Kansas Medical Center, NICU. She is a board certified in neonatology, pediatrics, breastfeeding, and lactation medicine. She is also the medical director for lactation services at Children's Mercy and the chapter breastfeeding coordinator for the Kansas chapter of American Academy of Pediatrics. So welcome, Dr. George, and I'll let you go ahead and take the wheel.
Thank you, Carmen. Good morning, everyone. Let me share my slides here. Second. All right, can you see my slides?
Yes.
All right, so let's go ahead and get started. So I wanted to talk a little bit about HIV and breastfeeding. And this topic is probably well known to all of you because these guidelines are not hot off the press. They've been around for a few years, but I wanted to talk about it because, it's still a little bit of a challenge to implement in practice. And even though these guidelines have been endorsed by CDC and AAP, there's a lot of hesitation actually supporting women with HIV who want to breastfeed. So I wanted to talk a little bit about the background, how these guidelines evolved, and are there still risks? And what should we? How can we best counsel our moms so they can make the safest and most appropriate decision for their babies? So I'm having a little bit of trouble advancing slides. There we go. So as I mentioned, these guidelines have evolved over several years. So WHO, they always make recommendations on a global scale. So their recommendations have always balanced the risk of acquiring HIV via breast milk versus the risk of malnutrition, GI illness, and death if they're not breastfed. Because we know in many parts of the world, there is no access to safe formula and safe drinking water. So not being breastfed is very risky. So WHO has always supported women with HIV in breastfeeding their infants, especially in areas of the world where there is no access to safe formula. And since 2016, they added the recommendation that moms should be on antiretroviral therapy and there should be prophylaxis for the infant. CDC, on the other hand, because it's obviously mostly focused on the United States, CDC had a strong stance for over 4 decades where maternal HIV was an absolute contraindication to breastfeeding. So in 2023, when this update came out where they supported shared decision making, that was a big change. So in 2023, CDC updated the recommendations to say that we should move to a patient-centered approach. And when we have an individual with HIV who are compliant with their therapy and have consistent viral suppression, they should be counseled on the risks and benefits, discussed with the options of formula feeding, feeding with donor milk where possible, or breast or chest feeding, and non-judgmentally supported in their decision. And that individuals who choose to breastfeed should be counseled on the risks and benefits and supported in adherence to their treatment. We should emphasize the importance of viral suppression and continued postpartum care for themselves and their babies. So, understandably, after 4 decades of saying absolutely no to breastfeeding when you have HIV, this was a big change, right? And then AAP endorsed these recommendations in 2024. So these guidelines have been out now, like I said, for over 2 years. It's not hot off the press. Um, but there's still a knowledge gap among the healthcare providers about these updated guidelines. The persons living with HIV are more informed than we are, and oftentimes the providers are lacking behind and catching up to these updated guidelines. And at the same time, I also feel like there's a knowledge gap in understanding the actual risks. It's not as simple as saying if you have a negative viral load, you can breastfeed. We need to have a more nuanced conversations around what is the actual risk. So first of all, why did these guidelines need to change? We have about 5,000 infants per year who are born to women living with HIV. And we have evidence that the risk of transmission via breast milk is low for those persons living with HIV who have achieved consistent viral suppression. A growing number of women living with HIV report that they would like to breastfeed. We also have to consider equity and cultural norms. So if, for example, in many cultures, in most cultures, in fact, breastfeeding is considered an integral part of motherhood. And to the point where in some cultures, if you don't breastfeed, it is a huge blow to their maternal role. And in some areas, if you say you cannot breastfeed, in some cultures, it's kind of like announcing their HIV positive status to the community. So we have to consider those norms into the equation. This can be particularly challenging for our immigrant and refugee population, especially when there is a discordance in guidelines from where they were before. For example, if a mom who was living in Africa had a baby there and breastfed her infant, and she immigrates to the United States, and now you're saying you cannot breastfeed the second infant, that is confusion, and there's a lot of frustration, and what is the evidence behind that? So this can cause a lot of confusion. There was a survey in 2017 among US adult infectious disease physicians, and it kind of showed what we already know, that if you take a paternalistic approach, to quote Dr. Harris's talk from before, if you take a paternalistic approach and do not engage in a shared decision making, persons living with HIV who desire to breastfeed will do so without disclosing to the medical team. And this takes away that opportunity to mitigate the risk and is more risky for the infant. So that 2017 survey showed that about 1/3 of the physicians reported that they have patients who breastfed despite the recommendation to formula feed, because this is before AAP and CDC changed recommendations, right? So in 2017, HIV was still considered an absolute contraindication. And at that time, 1/3 of the infectious disease physicians in the United States reported that they had at least one patient who breastfed despite the recommendations to formula feed. Now, what is the actual risk of transmission through breast milk? So one of the central dogmas in HIV transmission is U equals U, which means undetectable is untransmittable. And the big question is, does that hold true for transmission through breast milk? And the answer is we don't know, and most likely no, because the dynamics of transmission through breast milk is much more complex, and it also involves a prolonged period of exposure, right? So U equals U may not hold true for transmission through breast milk. Even when the maternal viral load is consistently undetectable, the risk of transmission is low. It's less than 1%, but it's not zero. And that is something that the mother who's deciding whether or not she should breastfeed her baby, this is something that she should know and be made aware of. There was this 2017 meta-analysis which looked at retroviral therapy started at some point during pregnancy and continued for 6 months postpartum while the mom breastfed. And the pooled transmission rate in that population was shown to be about 1.1% and ranged from 0.2 to 3.1%. And there was another big trial called the PROMISE trial, which looked at about 2,400 women with CD4 counts more than 350. And they looked at maternal ART versus infant prophylaxis. And the transmission rate was around 0.3% at 6 months and 0.6% at 12 months in both arms, showing an increased risk with cumulative exposure over time. This slide is busy, and I'm not going to go into the details of this, but I just wanted to give a visual representation of like the various studies that have been done across the world, from Africa to Europe to US and Canada, which looked at women living with HIV who breastfed their infants and compared different combinations of maternal therapy and infant prophylaxis and assessed what is the risk for transmission. So if you focus on the right side of the screen here, so the areas highlighted in red, those are the individual circumstances of transmission to the baby via breast milk, and then kind of describes what were the circumstances around this transmission. So you can see there is no red on this side of the screen. And those are the studies which looked at all those babies where moms were started on antiretroviral therapy before the third trimester of pregnancy and continued through breastfeeding. And in that situation, there are no reports of infant transmission. But that involves complete adherence to therapy, knowing that you have HIV prior to the third trimester and starting the treatment prior to the third trimester. So that seems to be the safest situation among all the different permutations and combinations here of treatment for mom and baby. But when treatment was started prior to the third trimester of pregnancy and treatment for mom and baby will continue throughout the duration of breastfeeding, we do not have any reports of infant transmission. And if you look at the individual instances where transmission occurred, all 17 transmissions occurred in situations where either mother's viral load was more than 50, there was report of poor ART adherence, or mom's therapy was started at less than 3 months prior to delivery. Because I'm a neonatologist, I always have to put a plug in for our preterm and medically complex infants. And it's important to know that there is no data on preterm infants. Theoretically, there might be higher risks. We don't know this. There's an abundance of a lack of data. We think there might be higher risks because these babies are known to have an immature gut, and increased gut permeability is always a higher risk for transmission of infection. But we also have to weigh that against possibly the higher benefits from being exposed to mom's milk. So we know that preterm infants benefit the most from having mother's own milk. So we do not know if those risks are balanced by the benefits. We do not have much data on critically ill infants. Potentially, again, there is more concern for a leaky gut and gut integrity and the risk of transmission. One of the recommendations if a mom with HIV chooses to breastfeed is to exclusively breastfeed, because we know that exposure to formula products can, again, impair that gut integrity and increase the risk of transmission. But we don't have a lot of data around, if you're exposed to a formula product, how long should you avoid using maternal milk? And that's, again, an area where there's a knowledge gap. Handling and preparation of milk in the NICU can be a challenge. For example, for a baby born at 23 weeks who will spend the next 6 months of their life in the NICU, and mom's milk is being handled in the NICU, possibly in a milk room. In our situation where I work, we have an 80-bed NICU, and babies are fed every 3 hours, so that's 8 feeds. So that's a lot of feeds being made in a day. And then there's always the worry about wrong breast milk being provided to another baby. And of course, the concern is heightened if you have a mother with HIV whose milk is being handled as well. And the medical legal implications of that are something that worry healthcare providers as well. Another important thing to kind of keep in mind is that even when the plasma viral load is undetectable, they can have a low viral load in milk, which is less than 100. And that might also be a factor to consider when you have a mother with HIV who wishes to breastfeed. Some of the other challenges for both the healthcare providers and the mothers to know is that we do not really have an established protocol for maternal follow-up. Most evidence suggests that viral load should be monitored around every 1 to 2 months. So it's very important to be in follow-up and ensure that your viral load remains undetectable for the duration of breastfeeding. There is no established protocol for infant prophylaxis, but most resources suggest prophylaxis for the duration of breastfeeding. There is lack of clarity on interruption. So what if you have to stop breastfeeding for whatever reason? We don't have, and presumably the baby might be either critically ill at that time or have exposure to formula. We do not have much data on the timeline to restart after these interruptions. But we do have data that shows that if both mom and infant are on treatment, the risk is very low. Again, follow-up for infant and monitoring for infant is also an area where we need more data, but it's recommended that infant have very close follow-up and have their viral loads even followed 1, 3, and 6 months after cessation of breastfeeding. The antiretroviral therapy has its own side effects, so hematologic and liver toxicity is something to be considered as well, and babies will need a lot of monitoring for that. So all that to say, the guidelines have been updated for a couple of years, but there are a lot of questions that remain, and the conversation certainly does not stop with your viral load is negative, you can breastfeed. There's a lot more to that, and we should educate ourselves so we can counsel our families appropriately and help them make the best decision for their babies.
Absolutely. Thank you. Thank you, Dr. George. I'm Brenda Bandy. I'm back. I've found my voice. Got to subbed in my husband's computer here. So thank you so much. And I think what I heard from both presentations is that these are complex issues that deserve conversations with the families that we serve and not just kind of a one size fits all approach to this work. So thank you both to Dr. Harris and Dr. George for the information and the reminder about that. So some exciting news for next month's emPOWER Talk. We will have Dr. Megan Azad from Canada to share research from the Azad Labs. And Dr. George, you will be returning again with another topic. We always look forward to your information and your perspective, both as a practitioner and as an expert in this topic. So we look forward to seeing everyone next month. Reminder, we have some lactation skills days that are coming up between now and then. These are half-day opportunities to get some hands-on learning around lactation. So we hope you will take advantage of that. And I think we have one more slide on the conference. Yes, conference registration. And just a reminder that we are going to be addressing these topics around substance use in lactation at our conference. We will have Dr. Teresa Baker back to address this topic. So let's continue learning together. We are excited to see you at the conference, and thank you for choosing to spend your morning with us. And we will see you back next month or maybe before then. Thank you, everybody.